All right, good evening. Welcome. Tonight we are talking about modernizing your comprehensive cancer rehab practice. So we have some excellent content from Dr. Stubblefield and Mary Callis this evening, and we will have an opportunity for some Q&A. So if you would submit any questions that you have through the Q&A icon, I do want to also remind you that this webinar is going to be recorded for a future playback. So we'll go ahead and get started. So for those of you who are not aware with Tactile, Nick, if you'd progress the slide. So a little bit more about our presenters this evening. We have Dr. Michael Stubblefield. He's coming to us from New Jersey, and he's the medical director for cancer rehab at Kessler Institute for Rehab. He's also the national medical director of Revital Cancer Rehab, Select Medical. So we're really excited to hear some excellent content specific to fibrosis and lymphedema in the breast cancer population. Mary Callis is also joining us. She is the senior clinical specialist with Tactile Medical. She is trained through Norton School of Lymphatic Training, and she's a cancer exercise specialist. She has several certifications through functional dry needling and therapeutic pain management. It just comes with, an extensive experience with cancer rehab. So excited to have Mary joining us. Then I'm your host tonight. I am the oncology key accounts manager with Tactile Medical. I've been with Tactile for about 6 years now, and my whole role is really looking deeper into cancer rehab facilities and how we can make the process as smooth as possible, and certainly focusing on education with the cancer rehab therapists and cancer centers across the central area. So we'll go ahead and kick it off. First, I want to talk a little bit more about Tactile Medical. We have some people who may be new to us. So for you, Tactile is actually headquartered in Minneapolis, Minnesota. We were founded in 1995 by a certified lymphedema therapist. We have about 1,000 employees, and we served about 90,000 patients in 2024. So the portfolio of treatment options includes FlexiTouch Plus, Nimble, Kylie, Entree Plus, and AffloVest. And our mission is to reveal and treat patients with underserved chronic conditions and help them care for themselves at home. So we really appreciate all of the partnership that the therapists that we work with provide in allowing us to live out that mission. So next, I do want to specifically talk about the new era of cancer rehab that we have entered. So it's really quite exciting. I'm sure some of you are familiar with the updated Medicare coverage. This is a really big deal because we had a pretty old restrictive policy that was retired in November. So this really has improved access to care specifically for our cancer patients, and specifically for those with breast or truncal involvement. So we're going to talk a little bit more about that tonight. We also have a really awesome partnership specifically with our cancer certified therapists. So this is content specifically developed for Revital Cancer Rehab, and really have had some tremendous success with fostering this partnership and working together. So at the end of the day, this is all about enhancing the patient experience, really doing right by the patient and what's going to serve them best long term. So we're excited to share some of this content that we've prepared, and hope to hear some of your feedback at the end. So on the next slide, there is, of course, some reasoning behind why we're modernizing, right? Why do we need to kind of change what it used to be? The reality is breast surgery practices are just far less invasive in the late 20th century. In the 70s, lumpectomy and radiation became viable and compared to a radical mastectomy. So just much less complex of a surgery and subsequent, symptoms thereafter. In the 90s, with an introduction of a sentinel lymph node dissection and the reduced need for a full axillary lymph node dissection, really just saw tremendously reduced, aggressive symptoms in those patients. And then in the 2000s, there's been advancements in oncoplastic surgery and nipple-sparing mastectomies for improved look. There's improved cosmesis and improved function, and really patients expect to look and feel good. They expect more and they're living much longer. Wonderful news for our breast cancer patients. So right now, the gold standard of treatment is the lumpectomy and radiation therapy. The supporting guidelines include NCCN, ASCO, and European ESMO. And then the common result is breast and truncal lymphedema. So that's what we're here to talk about a little bit more in depth today, just as a result of the lumpectomy and external beam radiation. So on the next slide, We will talk about how breast and truncal lymphedema is common due to, where the area of injury, where the lumpectomy site with scar tissue, the external beam radiation that does cause fibrosis and scarring, and therefore truncal lymphedema. So we'll talk specifically about cording, scarring, fibrosis, even put orange, the orange peel skin presentation that many patients do experience following those treatments. So on the next slide, so now I get to turn it over to the experts. So Dr. Stubblefield is going to talk about the prevalence of fibrosis and lymphedema. He's going to talk about proactive treatment to prevent the progression and improving outcomes with at-home management. These topics are in accordance with the NCCN guidelines, the National Comprehensive Cancer Network, especially specific to the at-home management piece and educating patients. And then he's going to turn it over to Mary Callis. She will talk through a 4-step truncal lymphedema assessment. So the skilled in-clinic care for truncal lymphedema and the clinical implications specifically to the FlexiTouch vest, which is now the covered benefit for Medicare beneficiaries. So we'll talk about documentation as well. So without further ado, I will go ahead and turn it over to Dr. Stubblefield to take it away.
Right. Well, thank you, Helen. Hi, everybody. My understanding is there's like 70 of you out there at watch parties. I think a lot of you are actually our own Revital therapists. So those of you who see me all the time, I apologize in advance. Hopefully you already know a lot of this information. So those of you who don't, again, I'm Michael Stubblefield. I'm the National Medical Director for Cancer Rehabilitation and Complex Medical for Select Medical. I'm the National Medical Director for Revital. I am Medical Director for Cancer Rehab at Kessler. I'm also a full professor of clinical rehabilitation at Rutgers. And as of recently, I'm actually the president of the International Cancer Rehabilitation Foundation, which we just started. So if my tactile colleagues don't mind me making a shameless plug, June is going to be Cancer Rehabilitation Month, and we're hoping to really start moving the needle even more with respect to people understand what we do for a living. Next slide. All right, so just by way of disclosures, again, those of you who've seen me know that I'm a pathological birth photographer, a playing doctor. I also photograph patients often because I find that having our own images are better than getting stock images. I am receiving an honorarium from Tactile for that, so thank you very much. And I'm the editor of Cancer Rehabilitation Principles and Practice, which hopefully will also come out in its 3rd edition in the next slide. All right. So we're going to just kind of start with this with something that I think you all know, and you can ignore the very complicated looking figure on the right to talk about fibrosis in general. Fibrosis is really scar formation. It's a normal response. Usually you cut yourself, you have to deposit fibrin to heal that wound. It involves platelets and fibroblasts and TGF-beta and a number of other things. And usually you will remodel that to be more or less normal. It may never be quite normal, depending on how old you are and how you were injured, but we've all been getting injuries our entire life, and we would be a train wreck if we didn't have a way to heal them. Fibrosis is really this excessive scarring. You can see it in keloid scars and other things where the sort of mechanism of it goes a little bit haywire, and you put a little too much collagen, or sometimes a lot too much collagen, where it should be. Next slide. So what is really important to remember from all of this is that if you have fibrosis, that fibrosis is affecting your lymphatic transit. So it kind of doesn't matter where you are. If you cut your hand, you are going to have to run around that area of fibrosis, at least temporarily, until it normally remodeled. If you've had a breast removed or you have severe fibrosis in the chest wall, you have a whole area of impaired transit for the lymphatic system as a result of all of that collagen being in places where it shouldn't be. So anytime you see fibrosis, you should really be thinking that that patient probably has some degree of lymphostasis in the area of fibrosis. Next slide. So the way this progresses really depends. And this is something I've made up to kind of describe just one possible scenario of how fibrosis progresses. And remember, everything we do to these patients causes fibrosis. So the surgery causes fibrosis. Certain of the systemic therapies we give them cause fibrosis. The radiation absolutely causes fibrosis. So depending on how we give these, depending if we're doing neoadjuvant chemotherapy or adjuvant chemotherapy, depending on how we're doing the radiation will really determine the degree of fibrosis. And I'll talk about later, there's a lot of individual variation in how patients fibrose. So just in this scenario, you start out at diagnosis, the patient may be perfectly normal. They go to surgery. You're not going to have fibrosis initially, right? But you are going to start developing fibrosis during the healing process. And that is going to get worse during the process of giving them systemic therapy, chemotherapy, and may get worse still with radiation. But remember, radiation's fibrosis is what we call the gift that keeps on giving. It doesn't happen right away. There's a lot of stuff I'll show you in another slide that does happen in the acute setting, but that usually calms down. And there may be this sort of honeymoon period where you have a relatively minimal amount of fibrosis that a year, 2 years, 3 years, 5 years can really develop. We see this most commonly, at least in my world, in the head and neck cancer patients. I also see a lot of Hodgkin survivors, but we absolutely see it in breast and gynecologic cancers where they were good until they weren't. And then sometimes when that fibrosis starts, the lymphedema comes right along with this. If you really quiz them, they may have had lymphedema even predating it. And then that fibrosis starts compromising certain structures. So I talk about in head and neck cancer patients how it can damage the spinal cord, nerve roots coming out of the spine, the plexus that was involved in the radiation field, any nerves that were in the field, like cranial nerve, spinal accessory nerve, another big cranial nerve, and then the muscles themselves can become fibrotic. And I call this a myeloradiculoplexoneuromyopathy, which is a fancy name I made up, really just to kind of show what the underlying pathophysiology is when a head and neck cancer patient, say, has a dropped head syndrome. In breast cancer, it really just may be a neuromyopathy, meaning that the nerve and the muscle are fibrotic from the radiation because there was no nerve root or plexus involved in the field. But the downstream effects are very similar in terms of the nerve damage, which can cause things like post-breast surgery pain syndrome, which, blaming it on the breast surgery, but frankly, the radiation obviously can be a big culprit. So the important thing to remember here from all of this is that fibrosis has this time course where you can get some early scarring. That may get better and try to remodel, but if you received radiation, you can see the scarring again many years later. And one of the big things patients will complain about is nobody told me this can happen. We see that all the time in Hodgkin's head and neck, and now in breast cancer patients with lymphedema, particularly with the breast conserving therapy we already talked about, it can become pretty profound and 3 or 5 years later. Next slide. So radiation fibrosis. I'm not going to torture you too much with this pathophysiology, and frankly, honestly, because I don't understand it too well, I'm not giving myself too hard a time because frankly, nobody really fully understands this process in its entirety. We've only been able to map little bits of it. But the basic idea is that all these reactive oxygen species, microvascular injury causes fibroblast and myofibroblast proliferation and activates macrophages, and you start depositing collagen, which is a normal tissue, but in ways it shouldn't be. It'd be like if I were to start filling my house with bricks, pretty soon I wouldn't be able to get to the bathroom. I wouldn't be able to get to the kitchen. It would become very dysfunctional around here because while bricks are a normal building material, you shouldn't have them stacked around everywhere. And that is basically radiation fibrosis. And as you can imagine, as we said, the lymphatics, which are very small and delicate, become damaged as a result of this fibrosis. Next slide. So lymphedema, right, is kind of a complicated process. It's not just a plumbing issue, right? And I remember when I was first at Sloan Kettering, and there were like 3 articles in the world on cancer rehabilitation, and I read them all. It took like an hour. One of the first monographs that came out was on lymphedema, and it had now like 10 articles in it. One of the articles I found most interesting was talking about how lymphedema is not just plumbing, but an inflammatory process. And what is important here, and you can see, the interleukins that are involved, TGF-beta, interferon gamma is all potentially involved in this. And all of that inflammation causes impaired lymphoangiogenesis. It contributes to fibrosis. There's decreased mobility and lymphatic dysfunction. And that causes more lymphatic stasis, which causes that protein and other cytokines to accumulate again. So you get this inflammatory response that causes more lymphedema. So that's this vicious cycle of when you get lymphedema, you'll get more lymphedema. And we know that if you treat early lymphedema, the patients do better, right? And part of that probably is because you're taking these, for lack of a better term, evil humors, right? All these cytokines and inflammatory mediators in the protein, and you're getting it back into the circulation where it's not going to be locally immunogenic and fibrogenic. So the important thing here is lymphedema begets lymphedema. You really want to treat the lymphedema as early and aggressively as you can to minimize the fibrosis. And I'm going to talk more about this in a bit, but I'll make the point, my head and neck cancer survivors, which is one of my biggest groups, I treat everybody. So it is very rare for a head and neck cancer survivor to not have lymphedema, right? If we look at it, the studies, you'll have external, internal, it's basically 97%, but I just say it's 100% of anybody with invasive head and neck cancer. So they all will be offered lymphedema treatment as a component of comprehensive therapy for them, which is going to be physical therapy, occupational usually for the lymphedema, speech language with a modified barium. Next slide. So that radiation fibrosis, right, that deposit of fibrin and other protein in places where it shouldn't be, is this slow, insidious process. It doesn't just start all at once. It kind of builds up over time. The DNA has been damaged by the radiation. The DNA has been damaged by everything we do to these patients. And it continues to get progressively more fibrotic. If it was just more fibrotic without causing symptoms, that'd be a shoulder shrug. But what we term radiation fibrosis syndrome are all those bad things that happen as a result of the fibrosis. So it's damaging literally everything that's in that fibrotic field. So it's damaging the nerve roots, the plexus, the peripheral nerve, the muscle, etc. It's damaging the skin, the fascia, the bone, any glands that are in the field. And everybody responds a little differently. So I'm guessing everybody here has probably seen at least one or two, and some of you probably hundreds of breast cancer survivors. And most of them who get radiation look okay, more or less. They don't look like this patient. But some patients, for reasons we don't fully understand, will have very severe fibrosis. And this is really just a lumpectomy and radiation. And you can see how it basically turned her breast into a raisinette, given the same type of radiation that the next person down the line probably would have gotten and would not have had this. So we don't fully understand why some patients are more fibrotic than others. Next slide. All right, so the determinants of radiation fibrosis risk and severity. So the biggest one is dose, the one we talk about. So breast cancer generally gets 50 gray and 25 treatments or fractions of 2 gray, more or less. Sometimes it'll be a little less with a boost. There's a number of ways, and I encourage you to look at the radiation treatment summary for your patient to see what they did, so it'll start resolving into numbers for you so that they start making sense. The fractions. So usually for breast cancer, it's 2 gray or 200 centigrade. That's the same thing. Fractions 25 times, right? So the patients, that's what they tell you. They're going to tell you, I had 5 weeks of radiation, meaning 5 times 5, 25, 5 days a week is the radiation they got. They don't know the top line number. They don't know what the total dose was, and they never know what the fraction size was. But you can kind of intuit from that their radiation was around. And again, better get the radiation treatment summary. The bigger those fractions are, the more damaging it is. The bigger the total dose, the more damaging it is. So we know from other countries where they've used different protocols to treat breast cancer that if you go up on the total dose and the fraction size, your risk of brachial plexus injury, for instance, goes up to like 75% in one of the studies, right, where they're trying to treat these patients faster and more aggressively. So there is a limit to what these tissues can absorb. The oncologic treatment, the fact that you had a mastectomy and axillary lymph node dissection absolutely factors in to the degree of fibrosis. The tissue type. So lungs melt with radiation. You give them half the dose you give to a breast. After 5 years, about half of those patients are going to have injury. Nerve is relatively, fortunately, resistant, but certainly not completely resistant. Protoplasm means does the patient have diabetes, a rheumatologic condition, or scleroderma, something like that. And then time. Again, it's the gift that keeps on giving. The further you get out from the radiation, the more likely you are to have radiation fibrosis. And if you're a head and neck cancer survivor and you got 70 gray, you live long enough, you're going to have fibrosis. And I think most of our breast cancer patients have some degree of fibrosis, even if it's not completely visible. Next slide. So The incidence of breast cancer-related lymphedema, it really depends, right? You'll see studies that say it's 2 or 3%. Studies will say it's 90%. It really depends on what you're looking at and how you're looking at it. We're going to talk. Mary will talk really about the assessment, and I will volunteer that she is much better than me at it. I have no doubt. But the truth is, almost all of your patients who've received a whole breast radiation are going to have some degree of lymphedema in the breast, and it's very obvious in this relatively young woman. And you can see that that breast is just swollen. And some patients won't tell you, others will. The breast will look completely symmetric. The arms will look completely symmetric, but they're going to complain that it feels heavy or just strange. Next slide. All right, so treatment. So this is one of the more important things. And those for you at working with me at Select Medical and really for everybody, I'm really hoping that I can change the treatment paradigm for how we do lymphedema. And here's why. So as working for Select Medical, we're a for-profit company. We work on very small margins. It's not like, we're doing unbelievably well and making exorbitant profits. We have to be very efficient, as all of our therapists know, with our time to stay in the black. And Medicare, frankly, doesn't pay us enough money in most of our markets to do lymphedema, where it's one therapist on one patient for an hour. We might as well just give Medicare a $10 bill. We get away with it because the private payers may do a little bit more. And now we're making $5 per patient. I'm just using kind of made up numbers, but you get the idea. And so what has happened is lymphedema treatment has really become a concierge service, right? If you have the means and you have access and there's a center near you, and you guys know not all places in the country, right? If you're in rural Kentucky, you may not have a lymphedema center near you. So what I'm hoping is that we can change the way we do lymphedema, particularly for the earlier stages, to be more about education and resistive exercises and weight management. We're going to get involved in a study on the GLP-1 inhibitors and lifestyle management for the lymphedema combined with a pump. And the reason we can get away with that now is because in the olden days, right, when I was doing the first textbook, the pumps were like 3 chambers. They basically just were kneading dough. So they probably did more to damage the lymphatics than to actually help. Then we got up to like our 8-chamber pumps, which are certainly an improvement in computer control going from proximal to distal. But now we have these computer-controlled multi-chamber pumps with a chest piece. So I'm not saying that they're, as good as a really good lymphedema therapist, which I'm assuming all of you are, but maybe they're good enough for the patients who have access issues or other issues that we can really start opening up who can be treated for lymphedema. And I think in the long run, this is going to be much better for them in terms of quality of care. It may actually even cost less given the hospitalization. Lymphedema patients have an increased number of hospitalizations, particularly for things like cellulitis. So I think right now, we're using it for home treatment after sort of the initial treatment. I use a tremendous number of them. I probably should even use more than I do. And breast and lower extremity, all of my head and neck cancer patients, after I've kind of got through their initial issues, are offered them. So anyway, I'm hoping you will all start thinking about how we can improve the management of lymphedema given the fact that we have this amazing new technology. Next slide. All right. So my last thing is really just early symptoms really warrant early diagnosis and treatment. So I am, radar up on every patient who comes in looking for lymphedema. If they're coming in with bad shoulder pain, it may not be the first thing that I go after, but I certainly have to think about it in any breast cancer patient, any gynecologic patient who walks in. I absolutely had a head and neck cancer patient who walks in. And the goal is we think that treating the lymphedema early and getting that protein out, which is fibrogenic, may decrease lymphedema. And there is some data for that showing that patients who are treated aggressive earlier probably progress more slowly than patients where it's just allowed to be there. Next slide. And that's it. So I have the pleasure of turning it over to Mary, who I really enjoy listening to much more than myself. So I'm going to go on mute and off camera now. Thank you, everyone.
Okay, thank you, Dr. Stubblefield. That was a great description of fibrosis and lymphedema and what happens with radiation. Go ahead and advance the slide. So I'm Mary Callis. I am a physical therapist, a certified lymphedema therapist. I am certified in cancer exercise. I worked in the realm of oncology rehab for over 25 years. Did receive specific training in that. I'm also specialized in functional dry needling and therapeutic pain. And I did do all that because I found that my patients benefited from that. They are very multifactorial and present with lots of issues. And really the goal is to improve quality of life and get them back to living. You can see here, I'm also an avid dancer. I do some ballroom dance, but I dance every weekend, rock and roll, you name it, any kind of dancing I love. Go ahead and advance the slide. So I know I'm just preaching to the choir, but cancer rehab is truly essential. Every patient who has a cancer diagnosis, who's had surgery, chemo, radiation, whatever the combination of treatments is, they really deserve to be seen by a cancer rehab specialist. And I really like this quote by Dr. Ron Carney. The difference between good cancer care and great cancer care is the rehab support following treatment, and nothing could be more true. Please advance. So based on what we've heard from Helen and Dr. Stubblefield, our current patient presentation is one that's more of truncal, breast, and chest edema. But we have this outdated assessment method. So even our EMRs still have multiple measurements in them for the limb, for the arm, but there may not be any place to document what we see in the chest, in the trunk, in the breast. And we always have to put in extra notes to make that so. So we really need to change our paradigm on what we're looking at, because very often if we can catch symptoms early in the trunk, we can prevent progression into the arm. And we know that even these improved surgeries, we see less arm lymphedema than we did maybe 10 years ago. Go ahead and advance. So I'm going to outline a very simple truncal assessment, starting with patient report, then followed by visual assessment, good palpation of the area, and where to take measurements, but keeping it more simplified because there, as a cancer rehab patient, there's a lot of areas you need to address in addition to lymphedema assessment. Next slide. First is a patient symptom report. This is a patient report that is provided by Tactile. You'll see that there are two columns, one for arm symptoms and one for trunk symptoms. This is a great tool that you could use when the patient checks in. Maybe they're waiting to see you. They might be in the treatment room. They might be waiting in the office area, but they can check these and help you identify what's going on by their report, how they feel it. You'll notice that these are very simplified terms. It's really in patient-friendly language. Research has shown that if a patient reports even one of these items of moderate severity, that they are associated with increased risk of developing lymphedema over time. So then we'll look at visual assessment. So I want to note, and Dr. Stubblefield did a great job of explaining this, no two patients are going to present the same. They all look different. It depends on the surgery and the treatment they got, but just their individual factors about how they heal. So in photo number 1, you can clearly see that the right breast is swollen. You can see the indentation from where their bra hit, and you can also see that the nipple is more elevated on that side. In photo 2, we see some very clear posterior axillary swelling. In photo 3, we can see some discoloration, hyperpigmentation. It looks to me, even without touching it, that tissue is probably adhered down to the chest wall, but we also see a pocket of fluid in the axilla. In photo 4, we see some redness, some erythema in the breast, indicative of inflammation and early signs of lymphedema, but we also see the distortion of the breast following surgery. In photo 5, that posterior view, this happened about 9 months after surgery. This patient clearly has some axillary swelling on the left side, and this patient might tell you that when they walk, they feel their arm brushing against their lateral trunk. Photo 6, we can see some induration of the scar. It's probably adhered to the chest wall, but we see swelling above and below. Photo 7, we see that pot orange texture, indicative of fibrotic accumulation there. And photo 8 is a little darker, but we can clearly see that there is some swelling along where that incision was, and you can really see that axillary increase in fluid. And also this would probably palpate as thicker tissue, more fibrous. Next slide. So it's important to note some patients are very obvious, right? The patient in this photo very obviously has fibrosis. There is adhesion of the scar, and where the skin fold is, that is adhesed down. You can see telangiectasia. That's a result of radiation. That speckling of the skin is something that we typically see. But on the right, you see a patient with less obvious fibrosis. That incision line doesn't really tell us a lot, but if you palpated it, it probably wouldn't move as well as the other side. And we still see a mild little pocket of fluid in the axilla. My point here is that it isn't always obvious swelling that we see, but sometimes it is the tissue changes that are the first clue that this patient has early signs of lymphedema, because there's no way that the lymphatics have not been injured in this process. Next slide. Here's another patient looking for multiple views. So you can see the right trunk. You can see a pocket of fluid. This patient had a lumpectomy with radiation, and there's that accumulation, and she complains of her arm brushing against her side when she's walking. When you compare it to the left trunk, it's not visible there, although as you go around the back, you can kind of see where her bra line is cutting into her back. So there is some edema there. And if you look at her posteriorly, you can see that the right side, that skin fold, there's more fullness there. If you're looking higher up, you may not see it, but identifying those skin folds is very important to see where that fluid is accumulating and pooling. Next slide. And also, a palpation is very essential to this assessment. So you can see that that breast is tethered down at the incision line. It doesn't lift, it doesn't move. More medially, the breast is easier to move and it's not painful, but it's very stiff. Right now, she's putting her fingers around kind of the radiated field, which typically can feel like almost like a hard rock under the skin. And patients can report that that's painful with movement. So it's very important to assess the mobility of the breast tissue. Next slide. This is a patient that we're looking at their mobility. Very important to observe this mobility with them disrobed. I'm going to let her go back down and I'll describe what's going on here. So in the resting position, this patient looks fairly normal. We don't really see a lot of difference side to side. And as she abducts, we start to see that fibrotic area with her, where her lumpectomy is. But as she goes to 180 degrees, look how the breast lifts and distorts. There's definitely tethering at that incision line and where she was radiated. This can be very painful. So it's very important to ask patients, to assess normal range of motion, because this patient essentially had normal range of motion, but she does not have normal tissue. And this is a breast that could develop into full-blown lymphedema. This is a method of grading fibrosis, grading induration from no induration to generalized, looking at the ability to move the skin parallel or sliding it side to side in multiple directions, or perpendicular to pinching it up, just like you do with a Stemmer sign. And it progresses to being able to slide the skin and unable to pinch the skin, and being able to slide, unable to slide or pinch the skin. Both of those can limit joint movement, can limit ADLs, and it can progress to generalized, which can be associated with signs and symptoms of breathing difficulties, because the chest wall, the rib cage may not be able to expand, and we may not see chest wall excursion and elevation. Next slide. The adherometer, it can be used to measure skin mobility and tissue adhesions. This has multiple concentric lines on it. You put the center of it at the most adhesed or tethered area, and you can measure it. So you can use this device. There's a scoring system to measure mobility, but skin induration. So this is a tool that can be useful if you want to quantify what you're seeing when you mobilize. Next slide. And then finally, for the assessment, it's important to obtain measurements of the trunk at evaluation and also 30 days later. And then, of course, whenever you re-evaluate. It's very important to measure the patient unclothed, have them lift their arms and put the measuring tape around them circumferentially, then have them lower their arms. So do that at the axillary line and then at the nipple line. And we know not everybody has a nipple on the other side. So sometimes you have to eyeball that. Or if one nipple is higher or lower than the other, sometimes you have to go kind of in between. What's important is that you document where you laid that tape measure and that you replicate it every time. Next slide. So how do we pair in-clinic care with patient-led home treatment? And this is where the paradigm shift comes in. So for those of you who are CLTs, we're very used to the phase 1 and phase 2 of CDT. But I want to think more in the more broadly in terms of cancer rehab. So I want to include more than just the lymphedema assessment. So that would start out with education and early identification and intervention of lymphedema, utilizing manual techniques, but very targeted manual techniques. They might be soft tissue mobilization, myofascial release, very targeted manual lymph drainage to areas of problems, providing compression garments. Aerobic exercise is very important because many of these patients have cancer-related fatigue or they have impaired they can develop cardiotoxicity, so they do need some kind of aerobic exercise program, whether that's the new step, a walking program, cycling, any type of aerobic exercise. We know from lots of research that resistance training is key, that we need to be building strength. And both of these also help with the weight gain that we see in patients. And I was happy to hear the Dr. Stubblefield mention the GLP-1s. Also, we often see patients with postural deviations, so they will become protracted and slumped. We know that affects their capacity for breathing. It contributes to pain. It's also important to do some breathing retraining with our patients. And then finally, something that's very key in the in-clinic phase is to initiate a demo of the pneumatic compression device, the FlexiTouch, to help develop a home exercise program, because we want to keep our care during this in-clinic phase skilled. We do not want to keep repeating MLD over and over. That is something that the patient can be doing at home. If they have a pneumatic compression device, they can get a good systemic treatment for 30 minutes to an hour a day, and we can more target our treatment and do more skilled activities. At home, then, the patient can have daily use of pneumatic compression. They can use their compression garments. They can continue the exercises that you've educated them in and their resistance training. We do have an app at Tactile called Kylie, so they can track their progress. There's lots of educational models. They can learn to measure their limb. They can track their own symptoms, and they can provide a report to you or to their physician. And then ongoing at home is having periodic in-clinic symptom surveillance, so ongoing touch points with that patient. Next slide. So here's a case study. This is a patient of mine that I met in 2011. She had stage 3 breast cancer, and she underwent a mastectomy, and I met her post-mastectomy and post-chemotherapy. She was awaiting cancer, she was waiting rehab. So you can see her scar is very tethered down. There was multiple folds, and all of those were adhered to the chest wall. This was important because this patient was an avid swimmer. She swam laps every day doing the American crawl. She also liked to play golf, and she liked to do Pilates. All of these were impacted. She worked for United Way, and she did a lot of promotional things, and she had to stand for long hours. She also had so she had trouble with that, but she also had trouble with concentration. She had cancer. She had chemo related issues that affected her ability to concentrate. I happened to be friends with her on Facebook, and we connected again in 2024. So this is 13 years post her radiation. And you can see the skin changes. You can see the increased fibrosis, the telangiectasia. Look at how her axilla changed. Look at the tethering of that tissue. So by that point, we met for breakfast, and I could also see that she had some upper arm, definitely lymphedema on the left side. Next slide. So I assisted this patient in getting approved for a FlexiTouch Plus. And this garment is designed to treat breast, truncal, and back lymphedema symptoms. It is a dynamic work and release compression. There's 1 to 3 chambers that work in a peristaltic action. What I really like about this design is that there are axillary straps, and patients get just instant relief from the filling and release of those axillary straps to really treat that and target that area where they feel the most pain and where we see the most symptoms. So if a patient just has chest or trunk lymphedema, we can use the vest garment only. If they already have some arm lymphedema, we can attach one arm, or we can treat bilateral arms, depending on what the patient presentation is. Next slide. So my patient got her FlexiTouch, and this is her results 2 months after. We did put a pad, a foam pad, like a Joby pad, underneath her pump to help soften that fibrosis. But look at the difference in the skin folds. And she was able to return to her lap swimming. She's still playing golf, and she's still doing Pilates. So she had some reduction in her upper arm, but the biggest change she saw was that that tissue was softer, her arm didn't feel as heavy, and it moved better. So let's move on. So what is our clinical reasoning for choosing the FlexiTouch over alternative options? Next slide. So here's a study that is looking at a patient pre-axillary lymph node dissection. Here's some ICG imaging. In that pre-axillary lymph node dissection image, you can see the very linear pathway of lymphatic drainage. That's still healthy lymphatic drainage. But as these images progress over time, you can see the pooling and the clouding and the disruption of lymphatic drainage. And so it's sitting in the tissues. And what we know from this study is that lymphatic dysfunction appears on image at an average of 8 months before we actually see swelling. So when the patient reports to you, or when you can feel tissue differences side to side, or you can hear symptom report of heaviness, pain, burning, any of those types of things, you need to suspect lymphedema before you can visibly see swelling. And why not intervene early and prevent that swelling from ever occurring? Next slide. Here's some more ICG imaging, looking at a patient who had lymph node dissection with a lumpectomy. And typically this area would drain to the ipsilateral axilla, but you can see that the system is struggling. It's trying to find a place to drain because there's been disruption from surgery and radiation and lymph node dissection, and we see this pooling in the chest wall. And this is very typical of what we hear our patients describe. It hurts under my arms, my chest hurts, it's worse during the day. And what they found with this studies is that 64% of the drainage still goes to the ipsilateral, is trying to go to the ipsilateral axilla. 7% goes to the ipsilateral inguinal area, 20.3% goes to the contralateral axilla, and 9.3% goes to the contralateral inguinal area. So the body is trying to compensate. It's trying to use the patterns that it knows, but the body needs assistance to help establish new lymphatic drainage patterns, and that's why our pump was designed to do that. So that explains the change in our design, and we're trying to take that lymphatic drainage inward and inferiorly to help it be reabsorbed and picked up by the circulatory system. Next slide. This is a study. This is images that show the mechanism of action. So we have in the chest piece, we have 32 rounded chambers that gently inflate and deflate to deliver a dynamic peristaltic pressure. So every 1 to 3 second intervals, you will see a filling and an emptying of those chambers. If you look at the ICG imaging in the pre, this is where the circle is. This is prior to putting on the FlexiTouch. There's no evidence of lymphatic movement, but in the post video, once the FlexiTouch has been applied, we can see lymphatic drainage occurring. So this really supports our product and shows that the mechanism of action does exactly what we say it does. Next slide. This is a randomized crossover trial that compared FlexiTouch use to self-MLD. We often hear from therapists, well, the patient's doing their self-MLD. That may be true, but how many patients can reach across their back to do good lymphatic drainage? How many are applying the right pressure? How many are doing it consistently every day with a good, effective technique? What this study found was that the FlexiTouch is more efficient and effective as a home program. So what they found was significant reduction in limb reduction compared to self-MLD, which actually the limb size increased, and a significant weight loss with using the FlexiTouch, and those patients actually had an increase in weight by doing self-MLD. So this really supports that a home intermittent pneumatic compression device can be an excellent option for a home exercise program and will allow you in the clinic to do all the other things that these patients need and will benefit from, and help allow you to provide more skilled care. Next slide. So in summary, therapists, I know that you add tremendous value to your patients, and it's important to keep your care skilled and provide psychosocial support and really look at every aspect of cancer survivorship. We don't want to minimize our value by offering repetitive MLD at each session when we can be doing things that are really going to help these patients improve their quality of life and get back to living. So let's empower our patients. Let's use this paradigm shift to help our patients be more successful and independent with a realistic home exercise program. And with that, I'll turn it back over to Helen.
All right. Thank you so much, Mary. That was excellent. Just a lot. Every time I've heard you speak, and of course, Dr. Stubblefield speak, I always learn something new. So I appreciate all the time spent on the research and the content development. So just a couple more key points to cover. I mentioned at the very beginning of the presentation the big Medicare news. So the retirement of an old, outdated policy in November that was very restrictive, that required patients to first get a basic device that covered the extremity. So now being able to bypass a basic device in order to go directly to an advanced, direct access to the FlexiTouch, specifically benefiting patients with breast or truncal lymphedema. So just a couple of quick little best practices, just being sure, just as Mary gave us some really thorough tips and tricks on how to assess the breast and the trunk. On the previous slide, you can make sure that you're assessing at evaluation and you're also obtaining measurements. So looking for those measurements at evaluation, that makes sure that the patient doesn't have to delay the course of when they would get the pneumatic compression. So making sure that first visit has a measurement, and then also documenting that either fibrosis or scarring, really make sure that we set the patient up for success, and certainly always reach out to your tactile medical contact to discuss the patient case and qualifying. Then on the next slide, so I was able to reach out to an exceptional therapist in our Austin area and just kind of learn a little bit more about her best practices. She's been working really well with her tactile medical representative, just has a really smooth, streamlined process. So I wanted to learn about how they have made it work so well for both of them. So her best practices, and I'm going to read some of her notes because they were so good. So she refers out of Val. And so Amanda Petter contacts her local rep, Liesel. She emails her with demographic information and the notes after she has communicated with the patient at the initial evaluation. So they talk about the pneumatic compression, about the process, and that Liesel will contact the patient. So then next, Liesel actually reaches out to the patient to get the demo set up and coordinates about scheduling in clinic, and then make sure that the tactile Amanda actually pulls up the tactile website to show the patient what the information, educational information on the website. There's videos, there's pictures, there's some patient stories. So she's very proactive because Amanda says her patients really need the tools for the maintenance phase. And she feels like the FlexiTouch is the best available on the market to accomplish the adequate carryover and to really ensure independence for her patient's care. So love to hear that. It's working really well for them. Then secondary, she treats patients with early symptoms. She uses the advanced pneumatic compression device early. So she says she suggests the pneumatic compression early in the process because the insurance process can be lengthy. So she's getting real with us. She knows that it takes time, and they have tools. She wants to make sure that the patient has the tool upon completion of therapy. So she wants that good carryover for home care, and it is the next best thing to if a patient were to able to come into the clinic daily, which may be quite challenging for the patient to travel into the clinic every day. But she wants that lymphatic stimulation every day for the best possible outcome and for successful independence for long-term care. So then finally, her third best practice is scheduling the in-clinic demonstration. So Amanda said that to schedule an in-clinic demo, she contacts Liesel, her rep, and they coordinate. And so if it's an in-clinic, then Amanda is also able to chime in on the education. So they can actually use a room where the therapist can come in, say, hey, this is why I'm recommending, here's how you can be using this. And for in-clinic demonstrations, they can all communicate together efficiently and they can get the documentation completed at that visit. So the patient can get answers from both Liesel, the tactile rep, and Amanda, the therapist. And it just makes for less confusion in overall care for the patient. So she feels like it's been a very successful process and has just kept things really streamlined. So thank you, Amanda Petter from Austin, for sharing your best practices with us. Certainly, we're always learning. So if y'all find some really effective ways, please share them so that we can help make sure it's smooth for everybody. So finally, on the next slide, we do have a tactile medical report card to share with you guys. So this is from 2024, and we are collecting patient feedback all the time. We really want to know how patients are feeling about their use of the treatment, about their experience with the tactile medical representative, about every point in their process with us. We want to know how the patient is feeling. So in 2024, we were able to survey 6,369 upper extremity patients, and we found that compliance-wise, 88% of those patients reported using their treatment more than 3 times a week. So they were really compliant. They were using it consistently. And they found that as far as ease of use with the Comfort Ease garments with the zippers, 90% are satisfied with how easy it is to get it on, get it off, and how to use it. So really excited about that feedback. And then as far as symptom relief, 84.1% reported less swelling, 52.8% reported less heaviness, and 35.4% reported less pain. So overall, just really feeling better because they've been compliant and because the garment has been easy to use. So on the next slide, we are going to wrap up with Kylie. So I'm not sure how many of you have already downloaded Kylie. I would highly recommend that you just take your smartphone and you scan the QR code here on the screen. But Kylie is your patient's personal lymphedema assistant. So we've had quite a few clinics that actually use this with the patient at the evaluation. So regardless of whether they're going to work with tactile medical for treatment using pneumatic compression or not, if they're not going to do that, if the patient's super early and doesn't really have symptoms, this app actually helps the patient track their own symptoms, and it gives them reminders for certain points of care. So if they're using a compression bra, or if they're exercising, they're elevating, they can actually check off that they've done those conservative parts of their treatment. So it really helps with their compliance, and certainly helps them kind of get that buy-in for coming into therapy and for managing symptoms on their own. Then it also gives them a graph. So here you can see where it's an arm and chest patient who's had pain and had swelling in the chest. Then she was actually able to rate her pain and rate her swelling when she first started with therapy. And then she saw that those symptoms improved. So as she was seeing her therapist, things got better, things got better. And then a whole, perhaps a month after visits, she's really feeling much better, and she can export these graphs. She can hang them on her refrigerator. She can share them with her therapist, or certainly her physician, and just really, knowing that there was an accomplishment with symptom relief from her therapy. And certainly if she's using the tactile medical equipment as well, then that is included. So definitely encourage you guys to do a check-in on the apps that you can then go back and show your patients, and help them kind of take the ownership and own the symptom management on their own. So on the next slide, I believe that is okay. So we end where we started. So together we are modernizing cancer rehab. There's no doubt about it. We are committed. This is certainly a huge initiative and focus for tactile medical, as I know it's very, very important to everyone on this call, is the long-term outcomes of cancer rehab patients. So we've finally got Medicare on our side. What a huge win. I've been celebrating ever since. We've just got better coverage, and we're able to really give these patients what they deserve as far as treatment long-term, that can be effective to manage their symptoms. We've got an incredible partnership with the therapists that are here, really being able to serve them together, and we're really able to enhance the patient experience. Live out Dr. Carney's quote that Mary read at the beginning, that really the difference between good cancer care and great cancer care is the rehab. It's the survivorship afterwards. So really just so excited to work with you all. And certainly thank you, Mary and Dr. Stubblefield, for your expertise. Y'all just do an incredible job. So I do see a question, which I'm going to go over here. So we have a question about the adherometer. And Mary, I know we talked about this. I actually use this in clinic as well. So Mary, where can you get the adherometer? And is there extra training that's needed to interpret the results? I have actually read the adherometer study recently. I'm not sure, Mary, if you want to take the question, or I'm happy to.
Go ahead, Helen, if you know the study, that'd be great.
Okay. Yeah. So the adherometer, it's a very simple, it's like a little piece of plastic. It's about this big, and it's a way you can even pick a freckle or a marker on the skin and stretch it in each direction. So you can actually, you can type in, on Google, adherometer clinical evidence, and there's a particular study, and then you can actually order the little circle, and it's literally a piece of plastic. It's very, very simple, and easy to replicate. And then the training, really, the study walks you through it, and it's just measuring by millimeters in each direction. So it's a very simple measurement that you can compare pre and post treatment. So it really gives you a good idea of, we had an increase of 8 millimeters of movement because of the functional exercise or the scar tissue massage that we've been doing in clinic. So documentation wise, again, very simple with measurements pre and post and a difference of millimeters of movement in each direction. So then another question that came through, we know that PCDs are perhaps more effective than self-MLD, but how would you go about navigating a therapy group that wants their patients effectively completing self-MLD long term? So you're wanting to, how do we work in the use of pneumatic compression combined with self-MLD, perhaps, Mary?
I think that, let me make sure I'm okay. I think that you could teach a patient to use their compression device 3 to 5 times a week, maybe, but have them throughout the day, maybe at particular times of the day. Say they're at work and they're at the desk. A lot of my patients say, oh, my chest wall feels so full during the day, because we know that the breasts are then in that dependent position and they're going to fill. That could be some time when they could do an abbreviated self-MLD when they go to the restroom or throughout the day. So I would encourage a patient to utilize twice, because as I said, self-MLD, nobody can direct fluid across the posterior chest wall, right? And that's a really important drainage pattern, and really getting effective systemic treatment over time that really helps encourage lymphangiogenesis and retraining the lymphatic system. I think it's essential to have both. And I don't think you're going to get that result with self-MLD alone, but I don't think it's a bad tool to use because it alleviates symptoms. It can alleviate pain to do some self-MLD throughout the day.
Yeah,
And if
makes
I
me
can
think of please, Dr. Stubblefield, yes.
all of that, absolutely couldn't agree more. But there's one other big point for me. What we've really been trying to do with the Revital program is emphasize the need for comprehensive cancer rehabilitation. You come for the lymphedema, but that is not your only problem. That's usually the gateway, the doorbuster that gets the oncologist to actually send them to you. This patient's going to have shoulder dysfunction. The patient's going to have cognitive issues, maybe neuropathy and gait dysfunction. I really want to help these patients live their best life. I want to treat everything that's reasonable to treat. And if you're spending an hour doing MLD on a patient that's going to home and then fall off the wagon and not be able to do it, you're really not getting them where you want to be. So I'm a big fan of teaching them, educating them, showing them how to do it. Mary's right, you can't get to the back. But then also working on the myofascial release and the shoulder range of motion, and the postural retraining, and all of the other issues that these patients really need to live their best lives. So that would be my answer. You got a lot of other important stuff to do. Let's do that as well.
I agree completely.
Well said. Well said. Lots of tools in the toolbox, but certainly, no limitations on what's going to be the most successful for each individual patient. So we do have another question. I know it's 8:01, but we'll have one more here, and perhaps for both of you. How do you introduce an advanced pneumatic compression device to a patient who has stage 0 or stage 1?
In my opinion, I do it. I feel that it's very important to educate my patients about all the resources and tools that are available. They may not have it on day one, but there's nothing worse than a patient coming back to you 5 years later and having them say, nobody ever told me, number one, that I could get lymphedema. Number two, that there was a device that could be used at home to attenuate these symptoms and prevent it from getting worse. So I think if we don't introduce it early, I would go ahead and do a pump demo in clinic, because it's part of education and providing resources to that patient to encourage, promote their own self-management over the course of their lifetime. And I feel like if we don't do that, then that's neglect.
Yeah, and we all know there's some patients they're never going to accept the pump. But I think Mary's absolutely right. You offer it. And you offer it early. And from my point of view, I explain that pathophysiology, that lymphedema begets lymphedema, and you want to treat it early. There's data supporting that. And, if you want to, minimize your risks of lymphedema-related complications, I would recommend the pump. And, for head and neck cancer patients, it's easy. I tell them because I truly believe it, and I really do believe for the others. If it was me, I'd be using it every day, right? And just that sort of self-endorsement may be enough. But then you still have someone look at you like you have two heads, and that's okay.
Can't win them all. You know what? We try our best, but excellent. Well, that concludes our program. It's a little after 8. Actually, it's after 9 for Dr. Stubblefield, so he's probably ready to go to bed by now. So thank you for staying up late for us, and really, truly, Mary and Dr. Stubblefield, thank you for the incredible content. So this webinar was recorded. We will have it available for an email afterwards. Any questions or interest in other topics, please send them my way. I'll send out an email and appreciate it. Thank you guys.